Hi, welcome to our webinar on the role of glove quality in maximising staff safety, sponsored by Arca Medical. I'm Louise Frampton, the editor of Clinical Services Journal, and I'm joined today by Dr. John Otter, a well-known researcher in the field of infection prevention and antimicrobial resistance. He's also the Director of Infection Prevention and Control at Guy's and St Thomas's NHS Foundation Trust. Now, John recently published a white paper which looked at both NHS and international recommendations for examination glove quality and usage, and today he'll be providing a deep dive into the essential use cases for gloves, critical factors influencing glove selection, the risks and costs associated with glove overuse, and the important role of glove quality. He will also share some best practices to enhance staff safety and effectiveness in glove use, promoting safer and more sustainable healthcare practices. This will be followed by a brief presentation by Gavin Cassidy from Arca Medical, and then there'll be some time for questions at the end. And I'm sure you'll have lots of questions, so please do enter them into the facility on the right hand side of your screen, and we'll get to those at the end. John will also be conducting a poll during his discussion, so please look out for this in the chat facility at the side of your screen a bit later on. Thank you. Over to you, John.
Hello everybody. I hope that you can hear me okay. I suppose the first thing to say is what a pleasure it is to be here with you today and to be talking about gloves, which is one of my passions, along with infection prevention and control. Now, so this is what we're going to cover today. We're going to have a think, first of all, about why we choose to wear gloves, and the fact that gloves are a really very important part of our box of tricks, really, when it comes to preventing the spread of infection in hospitals and also, crucially, protecting our workforce from exposure to organisms that might make them unwell. We also need to think really quite carefully about when to use gloves. The dynamic is changing in answer to this question. I think if we go back many years, the answer to when to use gloves would be really never. And that was initially because the right sort of gloves were just not available within healthcare. And then when the right sort of gloves became available, we began to think in straight lines about standard infection control precautions and the critical control points when people become exposed to infectious agents and how gloves can help to protect patients from exposure to the organisms on us and on our hands. So it is a changing picture, and bringing it right up to date, there is controversy about when we should use gloves and when we shouldn't use gloves. One critical question that I think it's fair to say probably hasn't had quite enough emphasis as you might like or even expect is which gloves do we use? We've decided we need to wear gloves for any number of reasons in the delivery of the healthcare that we're providing. But which type of gloves do we use? Because it's certainly true that not all gloves are the same. I think people are comfortable with the idea of a big distinction between wearing a sterile glove and a non-sterile glove. But within the world of sterile gloves, there's distinctions, and within the world of non-sterile gloves especially, there's distinctions that we need to be aware of and will help us to make better decisions when we're choosing to wear gloves. What's wrong with gloves? Well, I'll show you a powerful image of what can be wrong with gloves. This was a picture that I took on the steps to one of the hospitals in the group that I work for. I don't know whether this was a glove from one of our hospitals. I suspect that it was, given the proximity to the hospital door. And I think what it shows and illustrates, I think quite powerfully, is the risk of gloves and their onward journey. So if we think about where gloves are made, how they come to us, how they're cared for, if I can use that word, after they've been used in patient care, and where they end up at the end of their life, All these are really important questions that we're asking more and more as we start to think about sustainable healthcare and how we can deliver that across all of the services that we provide. And then finally, a final thought, really, some closing remarks about what we would consider to be best practice in the use of gloves, and how we can optimize the way that we use gloves to both maximize patient protection, but also to keep our workforce as safe as we possibly can. Now, throughout this talk, at some point around about the middle, we're going to cut to a survey on Mentimeter, which is, I don't know if you've used something like Slido, but it's similar to that. And it will allow you with a smartphone or with a computer to jump into the poll and to give us your views. There's a link that everybody should be able to see in the chat that I put in just at the start of the talk. And if you click that link, it should take you straight to the poll. You can do that now and be ready when we cut to the poll a little bit later on. So first of all, let's ask ourselves, why gloves? Why would we wear them? Under what circumstances? Well, I think there's two principal reasons for wearing gloves. So wearing gloves prevent exposure to our workforce or to microorganisms that can be hazardous to them. So in the left-hand side of this slide, you can see a flow chart, and this was hand sampling following 50 caregiver contacts with a patient with known VRE. And you can see that before patient contact, amazingly, 6 of the 50 already had VRE on their hands, and that raises a lot of questions in and of itself. After contact with VRE with a gloved hand, 17 of the healthcare workers had VRE on their hands. On their gloves, and even after removing the gloves, 5 hands were still positive for VRE. So you can see that gloves were helpful in preventing exposure to the VRE that ended up on the gloves, but they weren't infallible in preventing exposure to the healthcare worker hands, even when they were in the gloves. I think we see some similar data emerging from another study on the right-hand panel, where healthcare workers were exposed to mucous membranes, and a very high proportion of the gloves had gram-negative rods or enterococci on their gloved hands, and that reinforces really the need for wearing gloves, because if they weren't wearing gloves, these organisms would be on their hands. And again, just note that microbial contamination of the healthcare worker hands themselves were pretty commonplace in over 13% of the sampling events. And perhaps even more importantly, and very surprisingly, glove leaks were identified in a really, really high proportion of these patient contacts, and only 7 of the 32 of these leaks were recognised by staff. So the gloves were, I think I would argue that these gloves were not fit for the purpose that they were intended. And that's something that we'll come on to a little bit later in our thoughts. So here's a quote from EPIC around why gloves. The appropriate use of medical gloves provides barrier protection and reduces the risk of hand contamination from blood, body fluids, secretions and excretions, but does not eliminate the risk. And I think we've seen all of that come through in those 2 studies that we've looked at. So there is another reason for wearing gloves, and that's not to protect the wearer, but rather to protect other members of the hospital patient population. This is a really helpful review and meta-analysis of the impact of wearing gloves and some other items of PPE. And what this shows is that in the forest plot in the bottom right-hand side of this panel, you can see that the use of gloves and some other items of PPE was associated with a significant reduction in the transmission of a range of multi-drug resistant organisms. And now you can see from the forest plots, some of those lines are crossing the one, and that means that the studies were not statistically significant either way. It was only in the overall picture and in a few of the studies that we saw a significant reduction in risk. These studies were looking in the main at universal use of gloves. Now, this is not a strategy that I would personally advocate, and in fact, I think we're moving quickly away from the idea of universal gloving. But I think what this shows in principle is that gloves can help to reduce transmission risk. So reinforcing their value in the provision of care. So let's move on to the complicated question, actually, of when to use gloves. On the one hand, this is straightforward, but when we get into some of the more nuanced questions in this area, it does become a little bit more challenging. So I work in England, and in England we are led by a fairly new document, one that's quite well regarded and nicely evidence-based to the extent possible. It's called the Infection Prevention Control Manual. And it includes a section that is standard infection control precautions, and makes some recommendations around the use of personal protective equipment, or PPE, including the safe use of gloves. So the principles in this document are around the use of all PPE, so relevant to all PPE, not just gloves, but highly relevant to gloves. And that is that the use of any PPE should be dictated by an individual risk assessment. So we need to be clear thinking about what we're planning to do with the patient when we're deciding whether or not to wear gloves or other items of PPE. We should be aiming in principle to minimize the use of PPE. And if we do this, then it will result in safer care, because we know that extra layers of PPE actually introduce extra layers of risk, because you have to take the PPE off, and that brings with it inherent risks. Minimizing the use of PPE is also a more sustainable approach, because more PPE will result in more waste. And it's also a cheaper approach, because PPE is not free, it costs money. And whilst the individual item cost is low, if we multiply that by a healthcare system or even a national picture, the numbers can be quite staggering in terms of cost. PPE of all types is designed to be used for contact with a single patient, with a few exceptions. So when should we wear gloves then? So under standard precautions, non-sterile gloves are recommended when exposure to blood or body fluids, non-intact skin or mucous membranes is anticipated or likely. There are some procedures for which sterile gloves are recommended, and there are also some other procedures that are not sterile procedures where gloves are recommended because they are exposure-prone procedures, and we'll look at exposure-prone procedures, or EPPs, in a little more detail later. That's under standard precautions, so that's for all patients at all times. I'm not saying gloves should be worn for all patients at all times, but rather the risk assessment as to whether or not you need to wear gloves must be undertaken for all patients, for all patient contacts. There's also certain circumstances under transmission-based precautions where gloves are required, and we apply transmission-based precautions when we're dealing with patients with known infection risks. So this would be always when caring for patients who are either on contact or droplet precautions. Sometimes when caring for patients on contact precautions, and that would be with specific organisms and or following a risk assessment. So that would include things like multi-drug resistant organisms, those with increased potential for hand or environmental contamination such as C. diff. Now this is a change to the guidance. Previously, contact precautions, there was acceptance that you would always need to wear gloves. The latest iteration of this manual that I support almost gives us a way out of the need to wear gloves for every patient contact. If we're having contact with intact skin, even if a patient is known to be colonized or infected with a significant organism, the advice now is that we don't necessarily always need to wear gloves. Gloves are also recommended when caring for a patient with a high consequence infectious disease, or an HSID as they're described in this country, for which there are separate PPE recommendations. So this infographic image summarizes those principles in a visual format. So you can see there under standard precautions, there's no need for gloves unless there's anticipated blood and body fluid exposure. Whereas if there is, then you will wear gloves. And this is some visuals around how to put on and safely remove gloves. I won't go into any detail here, but just specifically around gloves, there's a recommendation to pull the gloves on with the cuff rather than touching the fingers, which are the parts of the gloves that are going to come into contact with the patient. And when we remove the gloves, to be careful not to contaminate our hands to the extent possible, and always to do disinfect hands with alcohol gel or soap and water after removing gloves, because as we saw from the initial part of this presentation, hand contamination does occur after glove removal for a fairly significant proportion of contacts. So here's a similar visual overview of PPE recommendations from the National IPC manual in England. For this time for transmission-based precautions, so you can see contact, droplet and airborne. For droplet and airborne, gloves are given, whereas for contact precautions, it's only where exposure to body fluids or blood is anticipated or likely. Switching my guidance to look at the World Health Organization. The World Health Organization have what I think is quite a helpful visual pyramid of the types of gloves that we might choose, or whether or not we use gloves at all. You can see at the bottom of the pyramid, i.e. most of the time, gloves are not indicated. Now this graphic has except for contact precautions, which is a conflict with the UK guidance, and the experts amongst you will know that is the way of the world. Not everybody agrees on these points, and there are areas of contention, even amongst expert groups, around exactly when and where we should wear gloves. But it's nice that the WHO gives some examples where gloves are not necessarily directly or not necessarily required. So taking blood pressure, various injections, etc., or indirect patient tasks like writing notes or tapping away on a keyboard, we don't need gloves for that. Whereas we do need gloves for various tasks. And this pyramid also includes the occasions when sterile gloves are recommended. So there's a little bit of really helpful detail around when the types of things we should and we shouldn't be doing when it comes to gloving. One of the things the National Manual talks about is no need for double gloving. This is actually quite a routine practice in many parts of healthcare, where an extra pair of gloves are put on as a sort of insurance layer, perhaps because of lack of trust in the quality of the glove. No gloves for near administrative tasks, as we've talked about. Gloves should be changed after each patient contact, which is kind of the easy bit. The harder bit is that they should also be changed after the completion of each procedure or task on the same patient. And to be honest, that rarely happens. If we look at the World Healthcare Organization's 5 moments for hand hygiene and think that we ought to be changing gloves after each moment for hand hygiene, if we were to do observational surveys, and not many people do them on this point, I think we'd find that it's quite rare for compliance with that kind of practice to be high. They should be changed if there's a perforation or puncture suspected. They should always be appropriate for use, fit for purpose and well fitting, and we'll look at some of those aspects in a little more detail later. Never decontaminated with alcohol-based hand rub or soap between use. We know that doesn't work, and it weakens the glove and makes them more prone to punctures. The glove material should be low risk of sanitization for the user. No, gloves must be appropriate to the task being undertaken, and that needs to account for the various elements. So looking at any substances that are being handled, the type and duration of contact, the sizing and the comfort of the gloves, and the requirement for both robustness and sensitivity. So it's no good having a really thick glove that's going to really protect your hands if you actually need to feel what you're doing to practice safely. So there's a little bit of a balance to be struck there. And I've mentioned before, the recommendation is to pull on with care to minimise the risk of contamination of the parts of the glove that will come into contact with the patient. And that is by holding them at the wrist only. Okay, so which gloves to use? Now this is the moment we're going to go over to the online poll. So if you could, if you haven't done so already, click the link in your in the chat. It should take you straight to the poll. And if I go to the poll now, can I just check from one of the organisers whether you can see the screen that I'm sharing there? Can you see the poll being shared? Yes, I've got a yes from the organisers. Fantastic, great to hear. Okay, so I can see the votes beginning to roll in now. Do keep them coming, because I'd love to have everybody who is on the call involved in this poll. Thank you to the small number of people who have clicked the like button. It may be that you pressed that by accident and we're actually looking to answer the question, but you did actually hit like, so that's always good to see. So when undertaking a surgical procedure in an operating theatre, I would choose sterile gloves, non-sterile gloves, or no gloves. So let's see, I can see that everybody who has answered this question so far has gone for the sterile glove option. That's what I would have gone for. I'm quite relieved that nobody went for the no gloves option on that one. Okay, so let's go to the next question. So your screen should advance. Here we are. So the next question. So this is in a different setting. When undertaking a procedure, when I come into contact with blood or other body fluids in a general ward, I would choose sterile gloves, non-sterile gloves, or no gloves. This kind of procedure happens all the time. It's a daily reality. Perhaps somebody who has diarrhea or vomiting, perhaps there is some open skin, or you'll be doing something with the patient that requires contact with maybe a mucous membrane. Appreciate that's slightly different to the question. Okay, so the vast majority of respondents, thank you for these responses, it's really great to see, have gone for non-sterile gloves, which is exactly what I choose too. So that is great. I'm going to move on to the next question. Oh, sorry, that's a duplicate. Okay, so the next question is, when caring for a patient with a high consequence infectious disease as my outer glove layer, I would choose sterile gloves, non-sterile gloves, or no gloves. So this is a patient with a high consequence infectious disease. So that would be things like Ebola or certain clades of Mpox, MERS, SARS-CoV-1, what else? Marburg, some other highly infectious viruses for which the consequence of the disease is very high, treatment options are limited, and or that they spread incredibly rapidly. So let's see a few more responses come through, and then we'll leave it there. So it looks like the majority have gone for non-sterile gloves here, which is a very rational choice and not one that I disagree with. A few people have gone for sterile gloves. Now, there could be a couple of reasons that one might be a misunderstanding of the use here. I don't think we really need sterile gloves to protect the patient here. It's not that we're doing a sterile task, but somebody may be saying, well, actually, sterile gloves are generally a bit more robust on my hand, and I'd like to have more robustness in my glove when caring for an HSIP patient. That may be a reason for choosing a higher quality glove. Okay, we're going to go on to a few more. And these maybe start to get us thinking a little bit more or a little bit harder about which kinds of gloves we might choose to use in this scenario. So when inserting a urinary catheter, I would choose sterile gloves, non-sterile gloves, or no gloves. So sterile gloves, non-sterile gloves, or no gloves for inserting a urinary catheter. Okay, so thanks again everybody for voting. This is great and very interesting. So vast majority have gone for sterile gloves here, couple for non-sterile gloves. So the most guidelines that I've seen would recommend sterile gloves for inserting a urinary catheter. There are some people and there are some guidelines that suggest non-sterile gloves may be okay. I haven't seen any that suggest no gloves here, but thank you for your responses. Okay, I think this is the penultimate question. Let's get a lot of responses to this one. So when inserting a peripheral venous catheter, I would choose sterile gloves, non-sterile gloves, or no gloves. You may be picking up a theme here in the various options you can choose, the sterile gloves, non-sterile gloves, or no gloves. Plot spoiler, they all have the same options that you can choose from. Okay, so response a bit slower to come into this one, which makes me wonder whether A, people are getting bored of these questions, or B, these are getting a bit harder. I think well, I hope it's the latter, and people are thinking more about these questions. So when inserting a peripheral venous catheter, I would choose sterile gloves, non-sterile gloves, or no gloves. And believe it or not, there's a recent expert opinion piece published on exactly this question. And amongst the experts, so this is experts in vascular access, some thought sterile gloves, some said non-sterile gloves, and some did say no gloves at all. So it slightly depends who you ask, but I think the majority position probably is non-sterile gloves here. Okay, and the final question in this set, so a big finale, is when cleaning and dressing a wound, I would choose sterile gloves, non-sterile gloves, or no gloves. Now, I've been deliberately slightly vague here about which wound and which setting, and I appreciate many of you are shouting at your screens whether it depends which wound and it depends which setting, which I'm sure, and it depends which patient, which I'm sure is absolutely true and valid. But what we're seeing here is actually the full range of responses for the first time. So we've got sterile gloves, non-sterile gloves, and no gloves coming through. I think there may be arguments for all three responses to this question. I think the majority of guidelines would suggest sterile gloves for this procedure, but also many go with non-sterile gloves, and it really does depend on several aspects of the context of this question. But I can see from this last question that in a group of informed people, and I imagine you have some level of expertise given that you've taken time to join this webinar out of your busy day, this question has divided opinion almost down the middle around which kinds of gloves that we should use, and that I think tells a story in and of itself. Okay, well look, thank you for getting involved in that survey. That definitely makes it much more engaging for me. I hope it does for you too. Can I just check whether you can see my screen now that's gone back to the slides? If the organizer could pop something into the chat, I'd be grateful. Just to let me know that you can see the screen there and see my slides. Slides are visible. Okay, thank you for the confirmation. Okay, so which gloves to use? Let's have a look at, with that in mind and that poll in mind, the National Infection Control Manual sets the following suggestions around which gloves to use. So we need to think about the clinical scenario: sterile, non-sterile, no gloves at all. Glove quality to ensure they're appropriate for use, fit for purpose, appropriate for the task undertaken in terms of comfort, robustness, and sensitivity, and also glove fit to make sure they're well fitting and certainly well enough fitting for the task at hand. So looking at those factors affecting glove choice from a slightly different angle, so not so much from the intended use point of view, but from the actual glove qualities point of view, there's a couple of factors that we ought to be really aware of. One of those is AQL, so it's the acceptable quality level, and it's a manufacturing term that really tells you how many defective gloves are detected during a batch of manufacture. Healthcare gloves typically range with an AQL of 1.5, so higher means slightly lower quality glove, to 0.65, which is a lower defect rate. Another key component of glove quality is tensile strength. So that's how far you can pull them before they start to tear. Gloves with higher tensile strength are less likely to tear during donning and during use. Healthcare gloves typically range from 6 newtons, so that's the force that we can apply before they break, right up to 12 newtons. Packaging and dispensing is really important as well. How many times have you put your hand in the glove box, pulled out a glove, and out come 5 or 6? What do you do with those? Guidance suggests you should throw them away. That feels wasteful. Some people put them back in the pack. I'm not suggesting that's a good thing to do. So glove inspection as they're packaged and how they're dispensed certainly influences how many gloves are wasted and may influence safety as well. It's increasingly become apparent that some aspects of the supply chain of PPE, particularly from some parts of the earth, are not good at all. There's seriously unethical parts of the supply chain with forced labour and just unethical practice. The other thing to consider is the sustainability of supply is increasingly important. And again, this is something that COVID taught us, that if the supply chain breaks, it can take a long time to fix it and to bring us the products that we need. Looking into AQL in a little more detail, so an AQL of 1.5 would suggest a defect rate of 1 in 65, and that's what you see with a standard non-sterile examination glove, whereas an AQL of 0.65 is a 57% lower rate of defects, 1 in 150, and you'd see that usually with a sterile surgical glove. There are some non-sterile gloves on the market with an AQL that low. So let's have a think then and just think through what are the consequences of incorrect glove choice. And I think there can be 2 major consequences. One is infection risk if we get our glove choice wrong. So we would introduce infection risk if we choose a non-sterile glove when in fact a sterile glove would be required. We introduce infection risk when we choose a glove with inadequate glove quality and it tears during care. So we've then exposed either the patient to what's on our hands or our hands to what's in or on the patient. There's infection risk when there's incorrect dispensing, and that could occur when a glove comes out, 2 gloves come out, you only want 1 or maybe 3 and you only want 2. We've got 2 hands. 1 goes back in the box and that's contaminated and introduces contamination to the chain. Gloves could be contaminated at source if they're not produced in a clean way. The other major consequence is if we choose the incorrect glove, there's not infection risk introduced, but we introduce resource overuse or over allocation. So that would occur when sterile gloves are used, when actually non-sterile gloves would have done. Then we use gloves that are more expensive and use more materials when we could have got away with a non-sterile glove. If we use an over-specified non-sterile glove when a cheaper non-sterile glove would have done, again, resource overuse ensues. If gloves are over dispensed and discarded rather than put back in the glove box, then we use more gloves than we need to. Double gloving is another area where we may introduce resource overuse through incorrect glove choices. So you can see how the differences in the choices we make around gloves can have direct consequences. Thinking back to the survey, there are some areas within this WHO pyramid that I think are contentious and have prompted lots of discussion. So, for example, exposure-prone procedures, minimally invasive surgery, minor procedures, and high consequence infectious diseases are all areas where you could argue, you could make a case for sterile gloves, you could make a case for non-sterile gloves, and if you made a case for sterile gloves, you might make it based on the fact that what you really want is a higher quality non-sterile glove, and that may be a better choice than sterile gloves in some of those areas. So thinking about minor procedures then, minor procedures are not always requiring sterile gloves. Urinary catheter insertional management, wound care, minor surgical procedures, and I fully accept opinion is split on these issues as we have seen before. There are areas where there's broad consensus in the literature, such as major surgery and general anaesthetic, disagreement as to when non-sterile gloves could be worn for some procedures, as we've discussed. And in these settings, a higher quality non-sterile glove may be a better choice. Exposure-prone procedures occur when healthcare workers are putting their gloved hands in areas where they may come into contact with sharp objects, and that may result in sharing of or exposing the patient to the blood of the healthcare workers, or equally the healthcare workers to the fluids of the patient. In this scenario, glove quality is a really important factor, and for EPP, it's especially vital that gloves of appropriate quality are selected. High consequence infectious diseases, as with EPP, it's essential that gloves of sufficient quality are used. The last thing we want is glove tears and rips to be occurring during an HSID scenario, where we want staff to feel comfortable that they have PPE that's going to keep them safe. So, what's wrong with gloves? Let me tell you a story. I had some visitors to one of our hospitals some time ago, and we were standing there on our critical care unit, and I watched a healthcare worker go to care for a patient, which they did, and then they wore a pair of gloves for that episode of care, kept them on, went and used those same pair of gloves on some medical equipment, dropped something on the floor, picked it up, went back to the patient and was just about to start manipulating a vascular access device. And I went over and I said, look, when did you last change your gloves? And I'm sorry, change gloves, wash hands, new gloves. Oh, and off they went. So, but I'm sharing that story because it's quite shocking, but it's also commonplace. That kind of practice happens day in, day out. And it's part of our role as being involved in infection prevention to illustrate best practice. It's not just me that has seen this sort of thing. This is some work that Jenny Wilson has done and shared before, and this is a slide that I'm using with her permission. And you can see a similar story really on the right-hand panel to the care that I observed not so long ago, with frequent contact of IV devices and other items where we really must be either not wearing gloves and doing hand hygiene, or certainly changing gloves before these contact points. So what's wrong with gloves? Well, gloves can provide a false sense of security to staff who feel protected and don't do hand hygiene or change their gloves when they should. They tend to be worn for way too long and certainly beyond the duration of the immediate task for which they're selected. Patients often feel uncomfortable with gloves too, especially for personal tasks. There's no doubt that gloves add a lot to plastic hospital waste. They're not free, they cost money, and they exacerbate skin health issues for all staff as well, which is an area we haven't really touched on, but there's some pretty powerful and quite sad data on that point. During the COVID pandemic, the world changed. It hasn't really changed back again. We saw an explosion of the use of gloves in the supermarket, but more pertinent to this discussion, in our hospitals as well. And the use of gloves became pretty universal in the care of our patients, and that has created an unfortunate legacy that we're trying to work through now and get across really good messages around when we should and when we shouldn't wear gloves. As you can see here, this is some guidance during the COVID pandemic in the UK, and you can see disposable gloves, single use for all direct care of patients in our hospitals. And that resulted in a massively significant increase in the use of gloves. I mean, we were already using a lot, but we went from using around about 2 billion gloves in the UK before the pandemic in 2019 to 5 billion gloves during the pandemic year, or the first pandemic year. So that was a huge, huge increase in the number of gloves. Gloves aren't free. We mentioned this before. They have a sustainability impact. We can see on this chart here, if we measure the carbon footprint of gloves individually, it's not massive compared with other items. But if we multiply that by the 5 billion gloves that were used during the first year of the pandemic, that's a pretty significant carbon footprint. And where does all that PPE go? I've seen the glove on the way into one of my hospitals, which may have come from one of our sites. People have done some ocean surveys, and this is sad. It's really tough to read actually, and found high levels of PPE turning up on the beaches around the oceans, and there's some other data corroborating these findings. And we can see the gloves there are ubiquitous. We still see them lying around, and they're sometimes littering the corridors and the wards of our hospitals. It's also true that gloves can become contaminated either during the manufacturing process or during patient care. I think quite often what happens is as the hand that goes into the glove dispenser or the glove box is itself not decontaminated properly, and therefore the gloves surrounding the one that's taken out or the glove dispenser itself becomes contaminated. And this was a microbiological survey of glove contamination at the dispensing source, and they found common bacterial contamination, some with organisms that could be significant as well, in a US emergency department. So in the last couple of minutes, I just want to have a think about best practice to gloves and how we can work together to promote best practice. We learned lots during the pandemic. One of the things that was very problematic in the early days of the pandemic was around PPE. And there was an awful lot of anxiety of healthcare workers who were really worried genuinely about their own risk of personal exposure. And one of the responses to that was to overuse PPE. It was being layered on with hats and scarves and overcoats and double overcoats and double gloving everywhere. And the underappreciated risk of all that was that there is a significant risk of hand contamination when gloves are removed. And that was a real problem, and I'm sure resulted in a fair amount of staff exposure to COVID, and continues to result to staff exposure to other organisms. We know that on-the-ground support has provided really vital help to patients, to staff rather, who are struggling with PPE, and that on-the-ground support is still required outside of the pandemic. It's also true that dynamic PPE risk assessments will never be the same again, and for that I'm grateful. I think staff are a lot more thoughtful about their use of PPE than they ever were before, and we can really help staff to make good decisions towards PPE best practice. This was the impact of a PPE helper program where a frontline team went and spent time in clinical areas talking to staff about PPE, answering their questions, and at the end of it, staff were more knowledgeable about PPE and made better choices. And finally, a thought around supporting staff to make good decisions about when not to wear gloves. Opinion on X was split when I asked the question about contact precautions, with 50% saying you definitely need it all the time. Others saying it would be okay unless there's contact with body fluid exposure. And another example really there of where opinion is divided. And finally, many hospitals are undertaking campaigns that are called Gloves Off or something similar. We know from Great Ormond Street, one of the first to do this, perhaps the first to do this, that it was successful and it resulted in significantly reduced numbers of gloves being used. Great Ormond Street is a children's hospital, so they illustrated the amount of gloves they were using in the number of T-Rexes they were using of gloves. I think it was 1 per year. We at Guy's and Tommy's have a similar campaign. We use London buses to illustrate the number of gloves we're using, but the conversations are similar. One of the most interesting aspects of the campaign is talking to staff about their perceptions around glove use and risks. And I think if I can get to the end of one of those conversations and the member of staff has thought really carefully and clearly about their rationale for using gloves and which gloves they use and why, I'm happy with that outcome, even if I disagree with exactly what they've decided. So to bring my thoughts to a conclusion, then, gloves have the potential to enhance patient safety and also healthcare provider safety in the care that we deliver. To realise the potential for gloves to actually make things safer, we need to adhere to best practices, absolutely. and make sure that the procurement of gloves that are of suitable quality is on the top of our priority list. Supporting staff to make good choices about the use of gloves is important and difficult, and it requires careful consideration of the right glove for the right application. We need to balance manufacturing quality in terms of AQL, tensile strength, packaging and dispensing, and supply chain issues in order to help staff make informed choices about the gloves that they're wearing to optimize glove selection and maximize both patient and staff safety. So with that, I will say thank you for listening and hand you on to Gavin.
Thank you, John, very much for your excellent presentation and for your exposure on your latest white paper. I would also like to thank Louise as well for and the team at CSJ for assisting with this, sponsored by ARCA. My name is Gavin Cassidy, and together with Corinne Jones, we represent ARCA Medical in the UK. But what is ARCA, for those who don't know our company yet? ARCA, formerly known as RACLAC, is a Portuguese innovative company that produces PPE, namely high quality examination gloves for healthcare professionals. We are the first company to manufacture nitrile examination gloves in Europe. We had the chance to be featured on the front cover of the CSJ last month, and on this issue you can find an article to get to know more about us. And our main goal is to be a partner with healthcare institutions to help mitigate the hidden pandemic of healthcare associated infections. Our fully automated production line enables us to inspect 100% of our gloves, ensuring our Advance are the safest examination gloves in the world, targeted for high-risk non-surgical procedures, as highlighted by John Otter in his presentation. Our gloves have improved specs, important to help mitigate healthcare associated infections, as John has previously suggested. And this is our previous, an image of our previous glove we worked on this year, and going forward, this will be our new concept. So our gloves have a really low AQL, meaning a lower number of defects allowed in the examination glove market, and it's 50% more resistance than your standard gloves, minimizing ruptures while donning or during procedure, and they're considered the cleanest, safest gloves due to its very low bioburden. Our packaging guarantees that the gloves will reach the healthcare professional with a in pure condition, and leaves our production plant because in an airtight and watertight packaging. It can be decontaminated whenever it's needed, and in addition, it allows gloves to be dispensed one by one by the cuff as per WHO recommendations. From our dispenser, it facilitates single glove dispensing by the cuff and enables vertical extraction, which is also proven to help reduce cross-contamination in the healthcare practices. We're currently working on adapters to fit our unique packaging in the current NHS dispensing systems, allowing an easier adaptation across high risk and general use areas in the hospital setting. Our Advance is totally aligned with John Otter's white paper, suggesting we should use less gloves and use gloves of a higher quality, especially for non-surgical procedures. And in order to help sustain the NHS system and environment to mitigate the hidden pandemic of healthcare associated infections. This process has been proven by trials performed across the UK in 2024, and we've achieved a glove reduction and also waste reduction of between 40 and 45%. We have been promoting the Advance for a couple of years in the UK now, and ARCA is currently preparing a relaunch of the Advance, incorporating the feedback received by healthcare professionals and partners. Going forward, we have a new colour, green, more aligned with our sustainability credentials, making it easier to identify our premium glove in healthcare institutions. Also, ARCA is reorganising its production to make our glove available at a more cost-effective price. Being produced in Portugal, we enable you to have supply chain resilience and ensures our gloves are compliant with Modern Day Slavery Act. If you have any questions, please let us know. But thank you very much for your time, and we would now like to answer any questions. And back to you, Louise.
Hi, thank you, John and Gavin. Some great questions coming through. So if I can ask John initially, should we be doing observational audits of glove usage, do you think?
That's a good question. We are in the habit of doing observational audits of hand hygiene. It's something we do systematized in most healthcare settings in the UK and many parts of the world. We don't necessarily have the same emphasis on observational audits of glove use, but actually when you run it through in your mind, it's quite difficult to justify not doing that, really, given the potential risks associated with the overuse of gloves. Perhaps there's some questions around the methodology that we might use and what would be a meaningful observational audit of glove use. But I do think in principle it's something we should look at very closely, and it would be beneficial, yes.
Have you got any advice on sort of the best kind of methodology for that? Is there any advice that you can give in terms of frequency of doing audits, or what are some of the sort of things that you found work really well?
So one of the things we've introduced in the hospitals that I work at is attaching some questions around glove use to our routine observational hand hygiene audits, so that we're maximising the benefit of the observations of hand hygiene. Because those of you who've been involved in observational audits of hand hygiene will know that it can be sometimes quite hard to actually get a significant number of observations. Some wards there's a lot going on, other wards things are quieter, and it can be hard to find the right number of the right sort of observations. So I think adding gloves to the audit methodology that we have already existing is a smart way to do it.
And why do you think staff wear gloves for too long? What do you think's the kind of motivation behind that?
I think there's going to be a variety of reasons for that. Some of them will be driven by wanting to protect the patient, and that would be the reason why they're wearing it, and perhaps just forget to take the gloves off between contacts. I think perhaps the most powerful driver is one of self-protection. When we look at the qualitative literature around glove use and glove overuse and extended glove use, what seems to come out most often is that staff are worried and they're concerned for their health, and that's the main driver for overuse of gloves and other elements of PPE. And you can understand it, can't you? If you're working with a patient who has an infectious organism, or you're doing a high-risk task, you want to look after yourself, and that's totally reasonable. And it's good for a healthcare organisation for the staff to want to look after themselves and to keep themselves safe. But that self-protection urge can go too far and create a scenario where, in fact, you're not protecting yourself anymore, and in fact, you're trying to protect yourself to the detriment of other patients, and that is clearly not a good position to be in. I think it's important not to become judgmental about the motivations for people wanting to overuse gloves. Self-protection is something we can't really help. It's inherent with us. It goes back to our cave dwelling days, but it's something that I think if we understand the motivation better, then we can begin to change behaviour. Yeah.
I've got another question coming through here. They're coming through thick and fast. So is there any education packages in existence that promotes the use of gloves and when they should and shouldn't be worn?
It's a good question. I've seen some good stuff from the Royal College of Nursing around the use of gloves and resources so that to ensure that the gloves are not overused. NHS England has also got some good case studies on various campaigns to try and reduce the excessive use of gloves. So that's two that I can think of. The National Infection Control Manual has got some more technical resources around some visuals for promoting best practice around glove use.
And what about the COSH side of things when preparing IVs? Organisations are following each other's gloves off campaigns, perhaps without scientific or empirical evidence, as medications have pH, this is quite a long question here, have pH values close to battery acid and concentrated bleach.
Okay.
Let's have a look.
Yeah.
What's your thoughts on
so
the legal COSH position?
Okay, so COSH considerations in the preparation of IVs. It's a really good question, and one that I've thought about a lot and been challenged about a lot, because I kind of see my role as challenging glove use and saying, well, do you really need gloves? So yes, you've always used gloves for that, but do you really can you justify the reason why you need gloves? If you're handling a substance with a battery acid pH, and there's a risk of that coming onto your hands, I think, yeah, fine, totally valid reason to wear gloves. But if the substance that you're handling doesn't have those COSH implications and occupation exposure implications, then the rationale for wearing gloves during IV prep is probably considerably lower. And there's similar questions around IV administration and manipulation of IV devices as well, where there's an awful lot of quite valid split opinion around when and where we should use gloves. And I think we're looking to the guidelines from the various guideline writers to keep pace with these discussions and give us some advice that ultimately is going to be a risk balance between glove use and risk, and where our risk tolerance lies is an interesting debate.
It's another interesting question here. It's in relation to modern slavery issues that you raised. So they ask, how important is the ILO F11 standard when choosing an exam glove?
I don't know what that standard is.
Okay, perhaps we can follow up after the webinar on that. Also, have outbreaks been linked to overuse of gloves in healthcare settings? Do you know if you've got any studies on that?
Well, overuse of gloves specifically, I think that's really difficult to tell, because in an outbreak setting, it can be so hard to really nail down the exact reason or cause for the transmission event. But certainly the overuse of PPE has been associated with outbreaks of healthcare associated infection causing organisms during the pandemic, where we were using PPE pretty universally, and PPE sampling was done and linked to outbreak strains of various organisms. So yeah, I do think there's a real tangible risk of cross transmission associated with the overuse of PPE.
And we've talked a lot about hospitals. What about community setting? Should we wear gloves in non-acute healthcare settings, do you think?
It's a very good question. I think the risk balance probably changes outside of a hospital. The prospects of encountering an antibiotic-resistant organism are considerably lower, but I think the principles remain the same in terms of delivering healthcare. If we're risking exposure to body fluid exposure and there's unknown infection risks associated with that, then it does make sense to wear gloves on some occasions during the delivery of care outside of hospitals. But I do think the risk balance is slightly different.
So I've got a question here for Gavin, actually. So do you believe that the gloves currently used routinely in healthcare settings are of sufficient quality to adequately protect healthcare professionals? And what opportunities do you see for improvement in the quality standards to enhance safety further?
Yeah, I mean, obviously they are gloves that are obviously fit for purpose within the NHS. We come from obviously a sustainability point of view, where our gloves are made in Europe rather than the majority of the gloves will come from the Far East, so Malaysia, China. So we focus obviously on, having zero impact on modern slavery. We focus on the quality. So obviously your traditional examination glove used in NHS is 6 newtons. We go above and beyond that. So we have an 8 to 9 newton so that's the force of break. So we ensure that our gloves won't tear when using, whereas if they're at 6 newton, we hear feedback from people where they find some gloves may be defective, but not all of them. So it's in certain, it depends obviously what brand, etc. you're using, the quality of gloves, obviously the chemical composition of the gloves, whether the percentage of nitrile is very important for our side. So we use 95% nitrile in our product, so that ensures a more elastic glove and more robust glove that's not going to tear, and also less harmful for your skin because we don't add any fillers that may obviously cause any irritation to your skin. And obviously the AQL is obviously a big thing as well. So your traditional examination glove is 1.5 AQL, and obviously the lower AQL the better. So the more testing of the glove, so less defective gloves, and the lower the AQL, the less amount of defective gloves that are allowed through from production to the end user. So yes, what you're currently using is sufficient, but we're offering a more sustainable and, in our eyes, obviously a better quality glove for the end user.
So I've got another question here for John and Gavin, actually. What is the current average waste in the current glove use within the NHS? Do you have any data on that at all that you can share?
Well, we obviously, on the numerous trials we have done, we can evidence a 40 to 45% reduction in waste. So that's by dispensing one by one, it's proven to help reduce the overuse of gloves and waste of gloves. So when you extract one glove, you should only get one glove rather than 4 or 5 gloves when they come out in one go. And if they come out in one go, you really should not use them if they've been touched or if they fall on the floor. So some people, if they put them back in, that happens, but it's obviously to reduce waste. But with ours, we allow for single extraction, so that ensures that the healthcare worker isn't under any obligation to put gloves in their pockets or back into the box. They've only touched one glove, and that they'll only get one glove by the cuff. So we would estimate roughly 40 to 45% based on our trials. But obviously it varies within each hospital of different dispensing systems. It's very hard for us to pinpoint an exact figure on wastage. It's all about AQL, so the amount of defective gloves allowed through that production process. So it can vary within what type of glove you're using and what dispensing system you're using as well.
Okay, got another question come through here. What would you recommend for an ambulance service professional who is allergic to the colouring in nitrile gloves? It's a good question.
Yeah, so obviously any question like that, we'd obviously recommend going to your occupational health nurse to get patch tested to make sure to find out what you're exactly allergic to. So if it is the colour, we can obviously assist in terms of offering information to that end user on a specific colouring if it is a certain chemical that they are allergic to. We found obviously during the pandemic a lot of people were using gloves from varying qualities, so they were getting reactions to a glove, and it wasn't not necessarily the nitrile itself. It may be the chemicals within that glove, the composition of the glove. So it all depends on the staff member. But obviously, number one, obviously go to your occupational health to find out what the problem is, and then number two, from our side, we're happy to help with the end user, with the staff member, to see if it's matching with what they're allergic to.
So we've got time for one last question, I think. Should trusts be doing their own testing of quality, and if so, what processes should be followed to ensure that that's done properly? Can you offer any advice or any experiences of how that can be done?
I mean, just quickly, Gavin, you may have a view on this, but I don't think it's realistic for each individual trust to do all of the tests themselves. It may be that individual trusts have specific questions that are relevant to them that they need to answer. But I think that there's a program of standard testing for gloves and for every other item that we procure. So I think it's more about trusts being assured that the relevant tests have been passed in a robust way in an appropriate test facility.
Excellent. I think that's all we've got time for today. So I just want to say a big thank you to John and Gavin for a really interesting discussion today, and also to all of you for joining in today and taking part in the poll as well. I just want to say thank you for taking the time to join us today.